All right, welcome to the deep dive. Today, we're doing what we do best, grabbing some really focused source material and really pulling out the absolute essentials.
Exactly, getting right to the core of it.
And the topic is lower urinary tract infections, UTIs. Super common, right? But definitely worth understanding properly.
Absolutely. And the material we're using today is, well, it's like I said, a revision notes, really high yield, designed to get you the key facts quickly.
Yeah, think of it as a fast track to getting clued up, whether you're prepping for something or just, want to nail the basics of lower UTIs.
And our focus is specifically lower UTIs today. We're sticking to what these notes lay out.
Okay, let's jump in. So the absolute foundation. What is a UTI according to these notes?
Well, the basic definition is pretty simple. An infection somewhere in the urinary system.
So that's kidneys, ureters, bladder, urethra, the whole setup.
The whole setup, yeah. And it's usually caused by bacteria. But right away, the notes make this really important split.
Lower versus upper.
Exactly. Lower UTI means the bladder, that's called cystitis, and sometimes the urethra. Upper UTI is, well, further up, ureters, kidneys, pyelonephritis.
Got it. And we're sticking firmly in that lower zone today, based on these notes.
That's the plan. And the notes give us more terms to work with, too, like uncomplicated UTI.
Ah, yes. What does that mean specifically here?
It's defined quite tightly. It's a UTI in a healthy, non-pregnant woman, no underlying urinary tract issues, not recurrent, and it rarely gets serious.
Okay, so complicated UTI is basically everything else.
Pretty much. Any UTI that doesn't fit that narrow, uncomplicated box. So being male, a child, pregnant, having other health conditions or structural problems in the urinary tract, being in care, or having them come back, often all that makes it complicated.
And knowing that difference is key for management, I assume.
Hugely important. It changes the whole approach, as the notes detail later on.
Okay. A couple more definitions from the source. Bacteriuria.
Just means bacteria in the urine. Simple as that. But crucially, it can be symptomatic, causing symptoms, or asymptomatic, meaning no symptoms at all.
Right. And recurrent UTI, is there a specific number?
There is. The notes define it clearly.
Okay.
2 or more UTIs in 6 months, or 3 or more within a year. Those thresholds are important.
Okay, so these definitions give us the framework, essential language.
Precisely. Helps classify things, which guides what you do next.
So we know what it is, how it's classified. How does it actually start? What are the causes, the etiology?
Well, the notes are very clear. Overwhelmingly, it's bacteria.
And is there one main culprit?
Oh, yes. The big one, the one you absolutely need to remember, is Escherichia coli.
E. coli.
E. coli. And the notes say it comes from the GI tract, the gut.
Typically, yes, which makes sense anatomically, the proximity to the urethra.
Right. It's not a long journey. Are there other bacteria mentioned?
Yep, the notes list others like Klebsiella, Proteus, and Staphylococcus species. And they briefly mention that viruses or fungi can be responsible sometimes, but it's less common. Okay, so E. coli is king, but not the only player.
Exactly.
Now, the pathophysiology, how do these bacteria actually cause the infection?
So the typical pathway described in the notes is ascension. Bacteria get into the urethra and literally travel upwards.
Up towards the bladder?
Precisely. And once they get to the lining of the urinary tract, they stick to it, they adhere, and then they multiply.
And that's the infection starting.
That's the infection. That growth and invasion leads to inflammation. And a lot of the symptoms you actually feel, the notes say that's partly your own immune system kicking in and responding.
Interesting. And how do the bacteria get in? What entry routes do the notes list?
The main road is the urethra, definitely. But they also mention entry via catheters during surgery, or sometimes, though less common, through the bloodstream, especially if someone's immune system is weakened.
And does this section mention the bacteria again?
It does, yeah, reinforces the main players. E. coli is flagged as causing around 80% of cases. Then you've got Staphylococcus saprophyticus, Klebsiella, Proteus, maybe around 4% each, according to some figures in the notes.
So really hammering home E. coli's dominance.
Absolutely. And understanding this whole process, the ascension, the sticking, the multiplying, helps explain why certain people are more at risk and why certain symptoms pop up.
Okay, makes sense. So we've got the basics, what, why, how. Let's move on to who gets them, how often, and what it actually feels like. Risk factors first.
Right. Risk factors. Who's more likely to get a UTI? The notes break it down nicely.
Okay. What categories do they use?
First, gender and anatomical factors, being female is a big one.
Why is that flagged so strongly?
The notes explicitly state it's the shorter urethra, just less distance for bacteria to travel to reach the bladder. Simple anatomy, big impact.
Makes sense. What else anatomically?
Things like structural abnormalities or blockages in the urinary tract, Pregnancy is listed too, and also menopause.
Okay. And then behavioral or medical factors.
Yeah, things like sexual activity, having had recent procedures or instruments used in the urinary tract, like a catheter check or surgery. Even recent antibiotic use is mentioned.
Antibiotics, how does that increase risk?
Well, antibiotics can sometimes wipe out the good bacteria that normally keep E. coli in check, sort of opening the door for it. Spermicide use is also listed.
Interesting. What about underlying health conditions?
Definitely. Diabetes is a risk factor, and anything that compromises the immune system makes you more vulnerable.
And any other major ones?
Urinary catheterization is highlighted as a major risk factor.
Mm.
Also, being in institutional care, like a nursing home, and maybe even a genetic tendency.
And having these factors often bumps a UTI into that complicated category we talked about earlier.
Exactly. It links back directly to that classification. The short urethra, the catheter risk. You can see how they bypass the body's natural defenses.
So given all these risks, just how common are UTIs? What do the epidemiology notes say?
Very, very common, especially in women and older adults. The UK data cited paints a clear picture.
Yeah. Like, what kind of numbers are we talking?
Well, consider this. UTIs make up about 23% of hospital-acquired infections. And a huge chunk of those are linked back to catheter use. Really reinforces that risk factor.
Wow, 23% in hospitals. What about in the community? Especially for women.
The stats are pretty stark. Up to 50% of women might have an acute UTI in their lifetime. Half. And then 20–30% of those women will get them recurrently.
That's a lot of people dealing with this repeatedly.
It is, and it increases with age. For women over 65, the notes mention about 21% having one within a 10-year period. Asymptomatic bacteria without symptoms, is also common in groups like pregnant women and older adults.
What about men? The notes say it's rarer for them.
Yes, much rarer in younger and middle-aged men unless there's an underlying issue. But similar to women, the risk really climbs with age, other health problems, being in care, and especially with catheter use. Asymptomatic bacteria also goes up in older men, particularly those in institutions.
So the takeaway is this affects a massive number of people. It's a huge health issue.
Undeniably. Chances are you or someone you know has definitely experienced this.
Right. Okay, so we know who gets it, how often. Now, the really practical bit. What does it actually feel like? The clinical features.
Yes, the classic symptoms. The notes list the things that usually make someone seek help.
Like needing to pee all the time.
Exactly. That frequent urgency and actually going more often, which is frequency or polyuria. Really key one is pain or burning during urination. That's dysuria.
Dysuria.
Got it. What else?
The urine might look cloudy or have a strong, maybe unpleasant smell. Pain is common too. Lower belly pain, that's suprapubic pain, or sometimes pain in the sides or lower back, loin pain.
And these symptoms are common enough to drive GP visits.
Very much so. The notes say UTIs account for 1–3% of all GP consultations, and they're the second most common reason for prescribing antibiotics empirically, meaning based on symptoms before lab results are back.
And E. coli is usually the bug found. It's still the main one, yeah. The notes re-emphasize the common symptoms. Dysuria, polyuria, maybe incontinence, that suprapubic or loin pain, the funny smelling or cloudy urine, and sometimes a fever.
Is there anything else listed under symptoms?
Yes, the additional information section adds things like painful frequent urination, sometimes seeing blood in the urine hematuria, urgency and incontinence again, but also more systemic signs like rigors, severe shaking chills, pyrexia, which is fever, nausea, and vomiting.
Okay, so it can range from fairly localized symptoms to feeling quite unwell.
Absolutely. And there's a really crucial point highlighted in the notes. Acute confusion, especially in older people, can be a primary sign of a UTI.
Ah, that's vital. Confusion in the elderly could mean infection even without the usual urinary symptoms.
Exactly. It's a key thing to remember, a major flag in that age group.
So with these symptoms, how do the notes say a diagnosis is made?
Typically, it requires having those characteristic symptoms plus finding a significant number of bacteria in the urine.
Is there a specific number for significant?
Yes. The notes usually quantify it as 105 colony-forming units per milliliter, 10 to the power of 5 cephalmol or more. It's a standardized threshold.
Okay. But what about that asymptomatic bacteria we mentioned? Bacteria present, but no symptoms.
Ah, yes. This is a really big point that notes stress. Asymptomatic bacteria is generally not treated.
Not treated at all.
Generally not. The major exception, flagged clearly in the notes, is during pregnancy. We'll definitely come back to why that exception is so critical.
Okay, noted. Pregnancy is different. And does the complicated versus uncomplicated thing come back into play with diagnosis?
It does. It helps frame the assessment. A healthy non-pregnant woman with classic symptoms probably has an uncomplicated UTI. But if the patient is male, a child, pregnant, has other health issues, then it's complicated, and that might trigger more investigation or different management.
Gotcha. And is there a kind of diagnostic shortcut mentioned?
Yes, for women under 65. The notes suggest a high likelihood of a lower UTI if she has 2 or more key symptoms, like dysuria, new onset needing to pee at night, nocturia, or visibly cloudy urine, and there aren't other explanations like vaginal discharge, and no warning signs of a more serious infection like kidney involvement or sepsis. It's presented as a useful clinical rule of thumb. So knowing these symptoms and diagnostic criteria helps decide who needs treatment and who might need a closer look.
Okay, so we suspect a UTI, maybe based on symptoms or that shortcut rule. What next? Investigations and management. How do we confirm it?
Right. First step, according to the notes, is always a good history and examination. Asking about previous UTIs, relevant medical history, sexual history, and a basic physical check focusing on the bladder and kidney areas.
Standard clinical practice, then urine tests.
Yes, urine analysis, usually starting with a urine dipstick.
What are we looking for on the dipstick?
Key markers mentioned are nitrite and leukocytes, white blood cells. Their presence suggests bacteria might be involved. Microscopy can also be done, looking directly for bacteria and cells.
But the definitive test is culture.
Exactly. A urine culture is described as essential for identifying the specific bacteria and figuring out which antibiotics will work against it. The notes stress doing this before starting antibiotics if possible.
Why before?
So the antibiotics don't kill off the bacteria before the lab gets a chance to grow and identify them. It's especially considered important in high-risk cases if initial treatment isn't working, or always for men.
Makes sense. Any other tests mentioned?
Maybe a CRP blood test if there's fever or flank pain, which might point towards an upper UTI or more systemic inflammation. And importantly, a pregnancy test for all women of childbearing age.
Okay. And when do the notes say you need to refer for more tests like scans or a camera look inside the bladder, cystoscopy?
Referrals is indicated if treatment isn't working, if there's a history of kidney or urinary tract problems, if there's blood in the urine that can't be explained, or if infections keep coming back, particularly recurrent infections in men or very frequent ones in women.
So, following the clues, if things aren't straightforward, is there anything about cancer suspicions?
Yes, there's a specific section referencing NICE guidelines. For men with urinary symptoms or blood in the urine, hematuria, prostate checks like PSA and a digital rectal exam should be considered.
And for hematuria itself?
Unexplained visible blood or persistent invisible blood on testing needs an urgent referral. And there's a specific point for older people. Individuals over 60 with recurrent unexplained UTIs should get a non-urgent referral to check for bladder cancer.
That age and recurrence combination is a key trigger then.
It is, according to these guidelines mentioned in the notes. So these investigations help nail the diagnosis, pinpoint the bug, and rule out other serious stuff.
Right. So once it's confirmed as a lower UTI, how is it managed? What does the management section say?
The main approach is antibiotics pharmacological treatment. The goal, simply put, is to wipe out the bacteria.
And how is the antibiotic chosen?
The notes say it depends on the patient's symptoms, the likely bacteria involved, and crucially, local antibiotic resistance patterns. But the primary choices listed for lower UTIs are trimethoprim and nitrofurantoin.
Okay. What about non-drug approaches?
Yes, non-prescribing management is mentioned. Things like simple pain relief, paracetamol, or NSAIDs are suggested. Staying well hydrated is important. And talking about those risk factors we discussed earlier to help prevent future episodes.
Any mention of cranberry? It's often talked about.
Yes, the notes make a very clear point here. Based on current evidence, cranberry products are not recommended for treating or preventing UTIs.
Okay, good to clarify that based on this source. What about how long to take antibiotics?
This is a really key detail for revision from these notes. The standard course duration is usually 3 days for uncomplicated UTIs in non-pregnant women.
Only 3 days?
For that specific group, yes. But it's longer, 7 days for men and for pregnant women.
Why the difference?
It reflects that men and pregnant women fall into that complicated category, or at least higher risk. The longer course aims for better eradication and reducing potential complications.
Got it. 3 days for uncomplicated women, 7 days for men and pregnant women. Anything else on treatment strategy?
The notes mention the option of a backup prescription in some uncomplicated cases. So giving the prescription but advising the patient to wait a day or two and see if symptoms resolve with just fluids and pain relief before starting the antibiotics.
Kind of a delayed start approach.
Exactly. But immediate antibiotics are needed for men and pregnant women, and a urine sample should be sent before they start treatment.
Okay. And who needs referral based on recurrence?
Men with recurrent UTIs generally need referral, as do women with recurrent upper UTIs or recurrent lower UTIs where the cause isn't clear.
And back to asymptomatic bacteria without symptoms.
The notes are very firm again, not treated in men or non-pregnant women. And routine preventative antibiotics aren't needed for people with long-term catheters unless they have a history of frequent or severe UTIs.
So knowing when not to treat is just as crucial.
Absolutely. Helps avoid unnecessary antibiotic exposure and resistance development. The different treatment lengths and approaches really tie back to those risk profiles and the potential for complications we discussed.
Okay, so what's the typical outcome then? The prognosis?
Generally good, according to the notes. With the right diagnosis and treatment, the outlook for a lower UTI is usually favorable.
Especially for uncomplicated ones.
Yes, uncomplicated UTIs often clear up quite quickly, usually within a few days of starting the antibiotics.
But the recurrent or complicated ones might need more.
Exactly. They might need that further investigation and ongoing management we touched upon. Links back to the referral criteria.
So mostly fixable, which is reassuring. But what can go wrong? What about complications?
The notes list several possibilities if things aren't treated properly or if it's a complicated case.
Like the infection coming back.
Yes, recurrent infections are one. A big one is the infection spreading upwards to the kidneys, causing pyelonephritis, moving from lower to upper UTI.
That sounds serious.
It can be. Sepsis, a severe body-wide infection, is another potential complication. And in the longer term, there could be kidney damage or urinary tract abnormalities identified.
Any specific complications mentioned for men?
Yes, the notes mention that men might develop an infection in the prostate gland, leading to prostatitis or even prostatic abscesses.
Okay. Now, you mentioned pregnancy being a crucial exception for asymptomatic bacteria treatment. Do the complications notes explain why?
They absolutely do. This section is critical. It highlights the severe risks of untreated asymptomatic bacteria in pregnancy.
What kind of risks?
If left untreated, the notes state it can progress to pyelonephritis, a kidney infection, in up to 40% of those pregnant women.
40%? That's incredibly high.
It's a staggering figure, isn't it? And it's not just pyelonephritis, it's also strongly linked to preterm delivery, having low birth weight babies, and anemia in the mother.
Wow. Okay, that completely explains why asymptomatic bacteriuria must be treated in pregnancy, even without symptoms.
Precisely. The potential consequences are just too severe. The notes emphasize that prompt, effective treatment during pregnancy really helps prevent these outcomes.
Understanding these potential complications really underscores why getting the diagnosis and treatment right is so vital, especially for specific groups.
Absolutely. It's not just about symptom relief. It's about preventing potentially serious downstream effects.
Wow, okay. We have really covered a lot of ground there, digging deep into these revision notes on lower UTIs.
We have, from the basic definitions and causes,
Through the risk factors, how common it is, what it feels like.
to the investigations, the different management strategies, typical outcomes.
And there's really important potential complications. It definitely feels like we've extracted the high-yield stuff.
That's the aim of using notes like these, to get the core knowledge efficiently.
And thinking back through it all, perhaps the most sort of provocative point that stands out for me, based purely on this material, is that stark contrast with asymptomatic bacteriuria. The notes clearly say don't treat it, generally, then hit you with that unless pregnant exception, backed up by that massive 40% risk of kidney infection if you don't treat it in pregnancy.
It's a very powerful example.
It really makes you stop and think, doesn't it? How something with no symptoms can shift from leave it alone to absolutely critical to treat just based on who the patient is, purely because the potential downstream consequences laid out in the data are so drastically different. It really hammers home the importance of context.
A perfect illustration of why understanding the nuances in specific patient groups, as outlined in these notes, is so fundamental to clinical practice.
Indeed. Well, that brings us to the end of this particular deep dive, focusing on lower UTIs using these specific notes. Hopefully you listening feel much clearer on the key takeaways.
Yeah, hopefully it's helped consolidate that core information.
That's always the goal, getting smart efficiently. Thanks so much for joining us.
Pleasure. It's a common but complex topic, definitely worth exploring properly.
And just a quick mention, the source material we've been working through today, this high-yield, focused style, it's very much like the resources you'd find for targeted exam preparation.
Designed for efficient learning and recall.
So if you are perhaps studying for something like the MSRA exam and you find this approach helpful, you might want to check out sites like passthemsra.com.
And also freemsra.com for more resources.
Exactly. Passthemsra.com and freemsra.com, they offer that kind of focused, high-yield material.
Definitely useful tools if you're in that revision zone.
For sure. Okay, thanks again for tuning into the deep dive. We'll catch you on the next one.